What's up, guys? Dr. Mo here, Digital Nomad Physician at digitalnomadphysician.com. You guys can go check out my website, digitalnomadphysician.com. You can email me, drmo at digitalnomadphysician.com. So, all right, I'm going to talk a little bit about urgent care medicine, sort of maybe family medicine, primary care, just getting back into medicine. For me, right now, being back in the US, it's a lot about working again, being in the clinic. There are two different groups that I'm working with. One is a family medicine group, so they kind of place me in different clinics. I've done a little bit of that. Primary care, slow pace, not crazy. Usually private practices that just need coverage. And another one is kind of a busier urgent care group. So I go to different locations. Usually they will drive me out with an Uber. So I'll leave here from my Long Beach apartment. They'll put me in an Uber at like 7, 8 a.m. and I'll go to some destination. I work for a 12-hour shift or an 8-hour shift on the weekend, and then I'm done. They drive me back with an Uber. And I get somewhere between $110 to $120 an hour, give or take, depending on the kind of shifts and stuff like that. So, I don't want to talk about that as much. I'll get into that maybe in maybe in one of the podcasts, or maybe I'll write something about it. But in this particular video, I really want to talk to you guys, the physicians, the family medicine doctors, the primary care doctors, or those of you who spend a lot of time in the clinic. One of the most difficult aspects of medicine to me is this human interaction that we have with another person, and the fact that we can really fear losing our medical license, getting sued. All of these things are kind of big, right? You kind of fear that something bad might happen. So you go in, maybe not fully being yourself, pretending to be a certain way, hoping that you're going to protect yourself, right? And that leads to this sort of downstream negativity, burnout, being jaded, etc., because you think that the certain actions you've taken have protected you over the years. Now, remember, for those of you who don't know this, who maybe are new to the YouTube channel, I'm a family medicine physician. I'm 40 some years old now, mid 40s, and I've been practicing since 2006. I've been moonlighting, and after finishing my family medicine residency, I mostly did urgent care, and I worked in large medical groups. I haven't been sued yet. Statistically, I will get sued, right? And inevitably there's a fear, and we're practicing defensive medicine. I'm practicing defensive medicine so that doesn't happen. I think maybe another perspective that I have been trying to cultivate is, what if I prepare myself for this supposedly inevitable lawsuit that I'm going to get? What if I prepare myself mentally, emotionally, physically, financially, socially, with my significant other and family and friends who could support me, so that I'm ready for this when this does happen? Because that's kind of a new paradigm shift, right? And I think for me, all of these new paradigm shifts have been very enlightening. They've really changed the way I've lived my life and practiced medicine. Back in 2016, I became fully financially independent, which meant I saved enough, I invested enough, real estate, investments, and I lived on a low enough income that I didn't need the money for medicine anymore. That didn't change a lot. I still had the burnout. In fact, I burnt out after that time. Or I was already burnt out, but I really, really burnt out after that period. And I tried to stay in medicine in some ways. I've dabbled in a lot of other stuff. And I think what I've found is I'm always chasing my own fears, the fears that I create, not the things that have happened. Still, I had a medical board investigation in 2017, which finally ended somewhere in 2019, probably close to 2020 actually. And I had license suspension in Oregon and another state. Here in California, I had to deal with it. And it was ugly, it was dirty, I was really upset, and I tried to change the way I practice. But in that experiment of changing my practice, I actually found something really unique and interesting. If I go into the medical office, if I go into the visit with the patient, and I come at it from like this hyper-vigilant, ready to attack, all right, I'm not gonna miss any medical things, I'm not gonna make a mistake, and I'm gonna make sure that I protect myself against this patient. If they wanna file a lawsuit, if they wanna write a negative review, and I would always go into it with this really strong mentality of protecting myself. And I don't think it helped, because most of the time when I was really on guard, I would actually walk in, the patient's super sweet, super nice, super kind, like they didn't have any odd things. Now, I also recognize that when I think back to these past couple of months that I've been working here in the urgent care, the patients that my mind lets me remember are the ones who were really difficult or complicated. Now, difficult maybe in the psychosocial sense, complicated in the clinical sense, but either way, I definitely was shitting my pants because of these patients. You know, one of them was somebody who I would call traditionally a drug seeker. And I'm trying to get away from that, and I'll tell you why. Not because I'm suddenly this enlightened creature. I'm trying to get away from that because if I call this person a drug seeker, then my mind is going to make me want to lump them into this one category, and this is how I should treat them. Instead, I'm like, let me go in, and this particular person wanted promethazine, I think with codeine or without codeine. Actually, I think it was just promethazine without codeine. And they were getting it multiple times. It was kind of obvious that they were in that cycle of getting it from some physicians and, not from me. But instead, I just went in. Well, I didn't in this particular case, but I have done it since. And now I go into the office visit, I talk to the patient, but I'm just slowing everything down. I have slowed down my pace completely. I'll get back to this case in particular in a few other more complicated medical cases that I've had. But I've slowed down my pace. So I'm focusing on dropping my shoulders. As soon as I see myself rushing and getting on the computer and I'm standing over a computer desk trying to look one thing up, I sit down, I do the deep breathing, like expand your diaphragm and your abdomen, not because this breathing is some magical thing, it could be, but for me, I'm now focused more of like just being in the moment and like, okay, well, I'm not gonna rush. So these are maybe the concepts that I've kind of developed for myself. I'm not gonna rush, I'm not gonna stress, I'm not gonna worry about something in the future, and I'm not gonna bring the past into it, and I'm gonna enjoy myself. So not bringing the past into it means if I have had a medical board investigation, I'm not thinking about that again, right? I'm not going to try to say, this is that one patient, this same thing could happen. Or if I know about some malpractice cases, I'm not going to think this could be that malpractice case, right? This is that clinical case that could really go sour. I think also slowing myself down means that I'm taking my time. I get a chance to breathe and I'm not rushing. If this particular medical group wants to fire me because I'm not seeing enough patients, or if there are patient complaints because somebody waited 2 hours, 3 hours, so let it be. This is a physician talking to you who has seen routinely 80 patients in 10 hours with very good patient satisfaction scores, everybody patting me on the back. The ER doctor's like, Dr. Mo, you're so fast. You're faster than the family medicine docs. You're faster than the ER docs. Patients loving me and stuff. A lot of ego, a lot of ego that I had before, and I still do, I'm sure, but it didn't serve me, right? I didn't feel any more protected because I was fast. Yes, I got a little bit of an ego boost from these other doctors, but it didn't serve me, it didn't serve the patients. Overall, it just created this havoc and chaos of burnout and everything. So instead, I wake up, I call the Uber when those guys tell me that I should go to work. Sometimes I'm 15 minutes late. Sometimes I'm 30 minutes late. In the past, I was an hour early, which is crazy to me. And there is value in that. There is value in being timely. There's value in being punctual, but maybe in a different setting, right? In a different setting. Now I'm a little bit late. I come in, put my mask on, I settle in, I have my coffee or water or whatever, and I'm just chill. I look at the chart. Okay, when is the patient in? Is the patient in? Great, I take a look. And, were the vitals done? Was a swab done if they need one? If was a urine test done, etc., x-ray. And then I go in the room and I've read a little bit about the patient's chart. Everything's going like super slow. Now, don't get me wrong, there might be a list of patients that are piling up. Before, I would look at this list and speed myself up according to this list so that I would be even faster. And I was thinking 5 patients ahead while I'm in with this one patient. So now I'm in with the patient. What's going on? Tell me a little bit about it. Oftentimes right now, obviously being January, it's the common cold and flu type stuff. But I had a kid visiting with his mom. Now I gotta, don't want to do HIPAA, so I'll just be vague, but they were visiting and from another place. And he really needed a lot of kind of more mental health type of support. They wanted like $1 million workup in the urgent care. And it took me about 30 minutes to talk to them about all the other things to consider. And we ended up not doing any tests, which was great. And I think they were very happy with the visit. It was good. It was really pleasant for me, and I think it was pleasant for them. But I spent like 30, 40 minutes in that room. I knew that I had like a huge list of people waiting to be seen. But that is the difference now. I'm taking my time with this patient, and then I'll go to the next patient. And when I'm with the next patient, I will take my time, I will listen, I will talk. I will go over that cough and cold and viral versus bacterial a million times. In the past, I brought the past in, and I had internalized the CDC recommendation and antibiotic stewardship, and I'm like, no, I'm not going to give an antibiotic. I will never give in. Now it's like, all right, I told you about the bacteria versus viral. You understand the risks of an antibiotic, and your choice is whether you want to be on this medicine or not. It sounds like you want to be, and I don't feel like this is something dangerous if I, prescribe this to you. So go ahead and prescribe it, and I'll justify it the best way I can in the chart, give return precautions, medication side effect stuff, and I just move on. And I'm like, I feel light, I feel less stressed. I'm not playing by the game and the rules that the medical board or maybe this medical group has set out for me. Instead, I'm just going by like, what is it that I would enjoy? I would enjoy just a genuine conversation with this patient, taking care of their UTI, taking care of their abdominal pain, vaginal issues, pelvic stuff. I was always freaked out about ever having a female patient in my room because I've also had bad experiences with that, and I didn't want to relive that. So for that reason, I'm like, oh God, pelvic exam, pelvic thing, which I'm really comfortable in. I'm really comfortable with my gynecology. And now it's like, I'll go in, I'll have a long conversation about what it is that they're worried about. Then I call in my MA, we go in, we do an exam, we talk about it, and then I have them dress. I go back in, we have another conversation, and it feels so good, guys. It feels just, everything is slowed down. Everything feels much less complicated. Now, where do I draw the line? Obviously, I draw the line if it comes to just giving antibiotics to everybody. I don't think that's really what you guys are hopefully hearing based on what I'm saying. I think it's more about, I'm picking my battles, I'm choosing my battles. I'm no longer that young resident or eager primary care doctor, young attending who believes that everything should be as perfect as it possibly can be. I certainly don't feel that support from the medical system, and that's not a bad thing to say about the medical system. The medical system is what it is. It's helped me with my hand surgery. It's functional, it's there, it's good, but I don't think it would support me in that sense. And so I do try to make the best decision possible so that I don't end up having to deal with a bad outcome. If I give antibiotics to everyone, right? Someone's going to look at my charts and be like, hey man, you're just a really shitty doctor. But I'm also not going to fault myself. I'm also not going to throw myself under the bridge. I'm not going to think bad of myself. When I am tired, I'm going to slow down, right? I mean, that's a big one for me. It's like when I'm having a bad day, let's say at the urgent care, and I feel like I'm easily overwhelmed, I just slow down. I take a deep breath and I'm just like, all right, this is not the day. I'm not thinking clearly. I need a little bit more time. Maybe, I have my UpToDate open. I have my other favorite websites open. I'm looking stuff up. I'm coming up with good decisions. Maybe I'll have a laceration followed up with a Bartholin cyst, followed up with like a peritonsillar abscess, all like waiting at the same time. And I say, all right, the peritonsillar abscess is stable and the Bartholins is going to be there for a while. And I'm just going to focus on this laceration. We're going to set it up. I'm going to talk to the patient. I'll step out of the room, regroup myself, go back in, have a conversation, slow back down. If he needs more time, if she needs more time, I'll spend the extra time and I'll let everybody else fall behind. And that is the way in urgent care is. That's why I don't have an appointment. Even if I did have an appointment, even in the primary care clinics, I'm just being less harsh on myself, but I'm also having less expectations of the patient. If you are coming there asking me for a medicine that I don't want to prescribe to you, we'll have a conversation, we'll have a discussion, and then I'm going to dig deep down and feel whether I'm comfortable prescribing this medicine. The other day I was going to prescribe a cough medicine for a patient because I really genuinely believe she was asking for this medicine, then it was not, she was not being a drug seeker, but the actual, it was a telemedicine visit, and that telemedicine platform particularly didn't allow it. So I'm like, okay, hey, I can't prescribe it to you, so what else do you want to talk about? No worries, no fears, no big outcome consequences that are like ruminating in my head. So the other thing I was going to tell you guys is about some of these clinical visits. I've had some really complicated things. Patient coming in with a fever and joint swelling and some other stuff, some crazy rashes and chest pains that came in last minute. And previously, I think because of having been a medical director at Kaiser and having seen a lot of these quality assurance, quality initiative, quality improvement cases, I've always been like a little bit more maybe conservative and say, okay, well, you got this. Oh, and I've been burnt on a new onset diabetes case. And when I say burnt, I mean, yeah, that was a bad outcome for me. And so what I did is immediately in my head, when I felt like, oh, you got to send this patient to the ER. There's nothing else. This patient just has to go to the ER. I'm like, all right, take a deep breath. Okay, we checked this patient out. We talked to them. We did the EKG. I couldn't do a chest X-ray, unfortunately. It was late at night. It was 8 p.m. And I talked to the patient. I said, hey, look, these are the things that I'm finding. A lot of the chest pains can be aortic dissection. They can be pneumothorax. They can be, all sorts of stuff that can happen in the chest that I can't evaluate without a chest X-ray. It doesn't look like it's PE. Doesn't look like it's a heart attack. So the things that I can't rule out. My recommendation to you would be to go to the emergency room and get this evaluated. And here right now, it doesn't look like something serious. I would actually lean more towards costochondritis and other stuff, but I cannot rule that out. Like, I haven't done the test to rule that out. So we had this conversation and it felt so good, guys. It didn't feel like I was protecting myself. It didn't feel like anything. And I didn't even, I didn't do an AMA against medical advice on this one. Somebody might argue that I should. I think I still could have done it quite well. In fact, I wrote, I'm like, we discussed the options. A patient at this time doesn't want to go to the, I didn't want to write refuse, right? I just wrote the patient did not want to go to the ER at this time. She understands the risks and complications. She's going to monitor the symptoms. And if it's not better, she's going to follow up with her primary care doctor. If it's worsened, she's going to call 911. But I did put like disposition, follow up with primary care doctor in 3 to 5 days, no matter what, for reevaluation. And I felt good about that because I'm like, look, I don't want this patient to fall through the cracks either, right? So I have learned some things from these past experiences, these past mistakes that I've done. All of this, if I had to summarize it, I would say I'm slowing things down. I am trying to connect with the patient, and I want to find that loving piece inside each one of these patients where I can just connect with them, whatever it is. Maybe they want to talk about automotive stuff, right? Like racing. Maybe they want to talk about woodworking. Maybe they want to talk about their job. I can connect with them on that. Even if they're being dicks, even if they're being assholes to me, even if they're being condescending, which honestly most are not, right? But it can seem that way. And I find that I'm having less friction in the exam room, but I'm also leaving the urgent care less stressed. I'm not, like back in the day, guys, I was dreading going to the urgent care. Now I hardly think about it. Like I have a shift coming up this weekend, not even thinking about it. It's not even on my mind. The only thing that's on my mind, I'm like, oh man, the whole day is gonna be gone and I'm gonna be tired. I'm not going to be able to go to that gym on that day, and that like some logistical stuff that I would also have if I had to go pick up some lumber from Home Depot or Ace Hardware, and I'm like, oh man, my day is going to be gone because I got to go pick up the lumber and then I got to come and install it. That's not a big deal. I'm not dreading, I'm not fearing it, I'm not fearing the consequence. When I leave the urgent care, I'm not thinking about the things that I missed. But there's a part of me that's very open and receptive to, hey Mo, you missed this huge case. You missed, what is that one called? Kawasaki disease. Or you missed this Kawasaki disease in a pediatric patient. Oh, I missed the Kawasaki disease in a pediatric patient. So now I gotta, this patient died and had coronary event. So then the patient died and had a coronary event, and I will deal with that. I will get the lawsuit, bring it, discuss it. I'll hire my own lawyer. I'll figure it out. We go at it one step at a time. All of the fear and frustration and ruminating that I did with my old medical board investigation up until very recently hasn't served me. I've been carrying that fucking weight from 2017 until recently, not now. I definitely don't think now. And it didn't serve me much trying to protect myself. And I think a lot of this came out with this really good conversation me and my girlfriend had about how we think that the consequences we fear and we protect ourselves against are actually protecting us, when they're not, right? I can say that, oh, well, because I am careful and I look both ways before crossing the street, that's why I haven't gotten hit by a car. Bullshit, dude. Bullshit. That's just, you can still get hit by a car and you can look both ways and you can be super careful. That doesn't mean that looking both ways in the street is like, you should throw it out the door. The point is that things can still happen. And for me, at least, it's more important how I view the universe and how I view my life and this career thing that I'm doing, and how I can make this medical career more sustainable, as opposed to just constantly fearing it or vilifying my patients, which is another thing that I have done, because I believe that, oh, because this patient, they're demanding this, they're expecting that, and this fucking thing's killing me, and like, look at this, and they're complaining, or they're doing this. And it's like, dude, the patient is coming to you for these things. The best thing you can do is offer the service that you can, and then walk away, and then you're done. Like, that's it. That's the only expectation I should have of me as a physician. I should practice the kind of medicine that I believe in, and I should be the kind of person I believe in, because if shit does hit the fan, and I've been a little bit true to myself, I've been genuine to myself, I've been kind to myself, it's much easier to forgive that situation, as opposed to if I've already been fake and I never was myself, and I was just being defensive, and I was just trying to protect myself, and I was vilifying the patient, and shit hit the fan. I think it'd just be ugly. So this was good. This was really helpful for me. A couple other things that I've done that have been kind of nice. I'm doing a mix of other stuff. I'm still spending some time doing my heart health coaching stuff. I'm really enjoying that. I'm learning some new things about what I want to do, what I don't want to do in it. I'm still in the functional nutrition course with Andrea Nakayama, and I'm doing the telemedicine with MD Live. That's going really well. I'm enjoying a lot of aspects of that. I'm still doing the work with Just Answer, answering some questions. It's a lot of learning in that as well. The primary care stuff is good. It's kind of boring to me, I'll be honest, but not like, it's mind-numbing a little bit, but not, I feel good. Like, I think some of these patients who come to me, they're very sweet, and they're like, oh, doctor, are you going to be my new doctor now? And like, I really like this other doctor, but you're so sweet. And that feels good. That does feel good. But I also recognize that I think that kind of relationship is not something that ongoing relationship is not always that desirable to me. The urgent care piece is much more exciting and much more interesting. And I've talked a lot about how urgent care is certainly on the rise. So that's it. That's kind of what I'm doing. And for the moment, this new methodology that I've developed has worked incredibly well for me. I feel like it's reversed some of these negative feelings and burnout symptoms that I've had. If it works for you, do it. If it doesn't, hopefully find something that is effective for you. I still am keeping my price down to $150 for consultations. You can go to digitalnomadphysician.com, go to the top right, and you'll see consulting, and you can book a session with me as long as it's still at $150. I am going to soon bump that back up to its $800, just so I can control the amount of time that I have free and available for you guys. But I think it's a really good price. So whatever you want to discuss, starting a new telemedicine practice, getting into healthcare consulting, dealing with burnout, medical board investigations, please reach out to me. And that is it. Take care, guys.